So today's topic is dilated cardiomyopathy, the most common cardiac disease in large breed dogs, as you all know. If we look at the signalment, then we can see that often it is middle-aged or older dogs that are presenting with symptoms of congestive heart failure. However, we may detect the disease earlier if there are screening examinations performed or if the clinician detects an arrhythmia or maybe a murmur. There is actually not a sex-linked in the dilated cardiomyopathy, although it appears often that male dogs are overrepresented. However, the explanation might be that the disease in males are often progressing more rapidly, and also male dogs have often a more severe disease progression. From the etiology, it is that most of the cases are familiar or idiopathic. However, taurine deficiency is well known to develop in American and other Cocker Spaniels, also sometimes seen in unusual breeds or mixed breed dogs that develop a taurine deficiency. And we have to think about nutritional. For example, lamb and rice diets were often under suspicion that they can cause a taurine deficiency. In some dogs, I have to say, because many dogs are fed lamb and rice diets and they never develop a taurine deficiency. Carnitine deficiency is hard to prove because you basically need a myocardial biopsy to prove that there is a carnitine deficiency. The blood levels are often not reflecting what is happening in the cardiac myocardium. In boxer dogs, it is reported in other rare instances. Another important disease would be tachycardia-induced cardiomyopathy. So if the heart beats like 220, 240 beats per minute for a period of like 3 weeks, then dilated cardiomyopathy can happen. So we have to keep that in mind, that sometimes, for example, in young Labrador retrievers, they develop, because of a supraventricular re-entry tachycardia, secondary dilated cardiomyopathy, secondary to the tachycardia. And then chemotherapy, for example, doxorubicin, might also cause a dilation of the heart with a systolic dysfunction. There are some news about the dilated cardiomyopathy concerning diets. Grain-free diets are more and more used by some owners because they think in the internet, they read it's healthier, or they have concerns about allergies. 19% of the dogs in 2016, for example, were on grain-free diets in the US. And more DCM cases have been reported when the dogs are actually fed grain-free diets. Also recently reported were 5 DCM cases that were fed kangaroo and lentil diets. Some dogs that are fed these grain-free diets, they also have a taurine deficiency, whereas others do not. So there's still research in progress. We also have to say that barfers also might develop taurine deficiency. Also there is more research ongoing. So if you diagnose dilated cardiomyopathy, it is actually important that you ask the owner about a good diet history. And if they are potentially on a grain-free diet, maybe you change the diet to a more conventional diet. Coming back to the dilated cardiomyopathy and the pathophysiology. So initially there is a decreased systolic function, which means the cardiac output drops and the blood pressure drops. Then the compensatory mechanism. So initially there's a sympathetic activation, but then on the long term we get a activation of the renin-angiotensin-aldosterone system, the RAS system, where more blood returns to the heart, which stimulates the myocytes to replicate, and that then causes the secondary dilation of the heart. This is what we also see on echocardiography, a dilated heart, a volume overloaded heart with a systolic dysfunction. Here we see the most commonly affected breeds. One is by far the Doberman Pinscher, but then we have also Irish Wolfhounds, Great Danes, Boxer dogs, and here we have the Cocker Spaniels. So we will talk a little bit about these differences in the breeds. Cocker Spaniels are usually not a big breed, so they have something special. And in the study from Mark Titelson, it was actually reported that these Spaniels respond to taurine and carnitine supplementation. So the dilated cardiomyopathy was reversible. However, today we know that Spaniels respond to only taurine supplementations, so I'm not giving carnitine for many years anymore, and the Cocker Spaniel on taurine supplementations can respond to the therapy. The procedure, if you have a Cocker Spaniel diagnosed with dilated cardiomyopathy, is usually that you draw blood and submit it frozen to measure the taurine level. If it's low, then you have a confirmation that there is a taurine deficiency. However, taurine deficiency can also other breeds beside Cocker Spaniels. It has been reported in Golden Retrievers, in Newfoundland dogs, in Dalmatians, especially if they are on a UD diet, then dogs on homemade diets. I already mentioned the grain-free diets, and mixed breed dogs that are on lamb and rice diets. Not only mixed breed dogs, but these are the dogs where we usually recommend to measure the taurine. So take a diet history, especially in these usually not affected dogs. So if a mixed breed dog comes to the practice and is diagnosed with DCM, it is worth to do a diet history. What is the special thing in Great Danes? Beside a high prevalence of about 35%, it is also more common in males. It is suspected to be an autosomal dominant transmission. Before it was thought to be X chromosome recessive mode with a suspected inheritance. But we think now it is an autosomal dominant transmission. Great Danes can have atrial fibrillation or ventricular premajor contractions here in the occult phase. And it is actually also quite common that ventricular premajor contractions can be seen in about 30% of the cases in Great Danes, according to a recent study and also according to our clinical experience. Irish Wolfhounds, they also have a special disease feature. They also have a quite high prevalence of about 30%. The mean age at the diagnosis is about 4 to 5 years. But then they have a very long disease progression. So it's slowly progressing. And the reason is probably that the beginning of the disease counts when they develop atrial fibrillation. And then I have to mention that not all Irish Wolfhounds that develop atrial fibrillation will later develop the classical DCM type, where they have a big heart with a poor contractility. That was also shown in some recent studies. So the take-home message here is Irish Wolfhounds, they usually start with atrial fibrillation, but then they do not need to progress to the dilated cardiomyopathy type in all of the cases. The boxer dogs, they used to have a disease which was called boxer cardiomyopathy, which is now renamed to arrhythmogenic right ventricular cardiomyopathy. Here we have a disease that is very similar to the same disease happening in humans, where we have fatty infiltrates in the myocardium replacing the myocytes, and that leads to typical ventricular arrhythmias with a so-called left bundle branch block pattern. And these fatty infiltrates usually start in the right ventricle, but later they can be also found in the left ventricle. These IRVC can present with two forms. In the first arrhythmia, they have ventricular arrhythmias with a normal myocardial function. That can lead to syncope, if it's not treated, even to sudden cardiac death. And this part of the disease may or may not progress to the classical DCM type, where we have here the myocardial failure. And in this stage, they also can have ventricular arrhythmias. And similar clinical presentations, syncope, sudden death, but they also can present with symptoms of congestive heart failure. Here are the typical left bundle branch block-like ventricular premajor contractions. So here in lead 2, they are upright. The T wave is opposite. This is, by the way, not a P wave. This is the T wave from the previous complex. So, but if they are upright here in lead 2, that is quite typical pattern for arrhythmogenic right ventricular cardiomyopathy. Then let's talk about Doberman cardiomyopathy. Here, the disease is also quite special. That in the beginning, in the so-called occult phase, where the owner thinks they have a normal dog, these dogs often start with having ventricular premajor contractions. If these VPCs are not detected, about 1/3 of the affected dogs will die suddenly. Later on, most of these dogs will develop the classical dilated cardiomyopathy type, where the dogs can develop pulmonary edema or right heart failure symptoms, pleural effusion, ascites. And then in that stage, another 1/3 of the affected dogs will die suddenly. The disease has a high prevalence of about 58%. So every second Doberman is affected by the disease. Here I have modified a DCM staging system similar to the one that we know in mitral valve degeneration. But here we have a little bit modification. So in stage A, we have no cardiac disease, but we have dogs that have a high predisposition, and it is recommended to do regular screening for these dogs. So, for example, in Dobermans, in Boxers, in Irish Wolfhounds, in Great Danes, and some other breeds, they should get regular screening examinations. But the dog has no disease yet. If we come to stage B, we have dogs where we have no clinical signs or symptoms caused by heart failure. And then we can subdivide also here in stage B1 or in stage B2. So I would suggest to say in stage B1 we have no cardiac enlargement, but we have arrhythmias, either atrial fibrillation, for example, Wolfhounds, or ventricular premajor contractions in Dobermans, in Boxers, and maybe in Great Danes. If the disease progresses, they get into the stage B2, still no clinical signs, but the dogs have cardiac enlargement that we can actually see on echo. Here's a little bit modification of the usual stage C, where we have C2 with mild or moderate symptoms of congestive heart failure, and then here is life-threatening congestive heart failure in C3. If we treat C2 and C3, the dogs will have no more clinical signs in the chronic phase, where we have stabilized congestive heart failure. And then if we are approaching stage D, that means we have refractory congestive heart failure that is not responding to optimal medical therapy. So I already mentioned the prevalence data in the US. It's between 45 and 63%. It appeared many years ago that the prevalence in Europe was lower, but according to many studies now, we know that the disease has a high prevalence also in Europe. When I came in 2003 back from the US and started at the university in Munich, I thought, okay, an interesting topic would be Doberman cardiomyopathy. So how do you start a research? Well, you ask the breeding association. So do you have any problems with dilated cardiomyopathy? And the response was basically, no, we don't have DCM in Germany. Well, then you continue and look in the internet, in some forums, and they also said, no, we don't have DCM. When you looked through some of these articles, you found that many Dobermans died suddenly. And there was a suspicion that it is due to some snake bites. So at that time I thought, that is strange, because we actually have no deadly snakes in Germany. So the path was started that it is worth to investigate into that disease also in Europe, because either I find this new snake that kills the dogs and only Dobermans, or the disease actually exists. So after a couple of years, we collected a lot of cases, and then we found an overall prevalence of 58%. And here is a disease progression, progression over the age. And as you can see, if they are quite young, we cannot diagnose dilated cardiomyopathy very often, but the older the dogs get, the more often we can detect it. So sometimes it is worth already to screen a 2 or 3 year old dog, because we can filter those dogs out that are already, or treat those dogs. And it is difficult to extinguish this disease if most of the dogs will develop the disease only with 5, 6 years and older. We also found in that study that males and females are equally affected. However, male dogs start earlier with the classical DCM type, so with a systolic dysfunction and a big heart, whereas the female dogs, they remain longer in the so-called arrhythmogenic stage. So it was previously, when the dogs did not get the 24-hour ECG, it was easier to detect dilated cardiomyopathy type, the big heart, because you only needed to have an echo. Whereas the female dogs, you need often a 24-hour ECG to diagnose the disease. What kind of clinical signs of DCM can we have?
So there are symptoms related to
arrhythmias. Those would be syncope. We could have symptoms related to left heart failure, low cardiac output, exercise intolerance, weakness, or actually having a weak pulse. If we have symptoms related to right heart failure, that might be ascites, pleural effusion, or jugular vein distension. And if we have the classical left heart congestive heart failure symptoms, that would be dyspnea, coughing due to pulmonary edema and enlarged left atrium, and also we may find arrhythmias. In the early stages, we usually find no clinical signs, or actually they are quite subtle. One would be a gallop rhythm, so you hear a third heart sound. Maybe you find a weak pulse quality, or a soft murmur, which would be actually secondary to a chamber enlargement. So if this is the mitral leaflet and the heart gets larger, the mitral leaflet here is pulled apart, and then a secondary leakage will occur, which we can hear over the mitral leaflet usually as a soft murmur. Arrhythmias are another thing that we could detect in the early stages. If the dogs have heart failure, we can detect dyspnea, tachypnea,
with an increased respiratory rate,
coughing, and then right heart failure symptoms, ascites, pleural effusion as well. So how do we diagnose the disease? If we want to diagnose the arrhythmogenic stage, we need an ECG. Atrial fibrillation is usually quite easy already to detect on a resting ECG or on an in-house 30-second ECG. If we want to detect here these guys, the ventricular premajor contractions, we have to think about how good or how often will they come on a short-term ECG. Often we need a 24-hour ECG recording, which is also called a Holter monitor. And depending on the breed, it is about more than 50 or 100 VPCs per 24 hours. The number and the complexity and the
beat-to-beat frequency
of these VPCs increase with severity with progressing diseases. They can have even 10,000s of VPCs per day. So if you have a lot of VPCs, you can detect them already on a short-term ECG. The likelihood that you detect one is quite high. However, if a dog maybe has only 300 VPCs or 1,000, you can calculate that the chance that
one of these is actually happening
in resting ECG is quite low. So how do we perform a Holter examination? So we shave the dog and then we bring these ECG pads on the dog on both sides. Then we wrap the dog with bandage. And then now we have the experience that if we use these special Holter vests, that we get better recordings. So here's the Holter vest on the dog, and the Holter monitor sits on top of the animal. So the animal can go home with the owner, and then after 24 or 48 hours, we take it off and put it into the computer software and analyze the Holter monitor. Why do these Dobermans die and some other breeds suddenly? This is actually what we can see here from a Holter that the dog had on when he died suddenly. So initially, first there was a sinus rhythm, and then all of a sudden this burst of ventricular tachycardia started.
And then it went into ventricular fibrillation.
And then here the dog unfortunately died. So it's these very fast VPCs that progress into ventricular fibrillation. What did we learn over the years concerning short-term ECGs, so in-house ECGs that most of you probably have in your practice? We learned from this study where we compared 875 Holter and 5-minute ECGs that if we found at least one VPC, then the likelihood that this dog will have more than 100 VPCs in 24 hours is actually very high. So usually we are not doing a 5-minute ECG, but if you think you're doing an echo and then you have your ECG of the echo machine attached, and then if you, during your echo exam, detect at least one VPC, that could be an argument to the owner that this dog has a high chance to have more and potentially dangerous VPCs. So this dog should get a Holter ECG if possible, or referred for a Holter examination. If we do not find any VPCs during 5 minutes, that does not exclude that the dog actually has the disease. What about the value of radiographs? Well, in the early stages, in the occult phase, we may not detect any changes, especially in stage B1. In stage B2, where we have echocardiographic detectable changes, the radiograph could also show enlargement, but it's probably for screening not the best test. If we have severe disease, then we see an enlarged globoid cardiac silhouette with left or also right atrial enlargement, pulmonary edema, and pleural effusion. But it is not a good screening test because to detect the systolic dysfunction and then early changes in the heart, that is not easy to detect on radiographs. Here on the other side we have a really big heart. So here's the left apex, left atrium here is enlarged. We also can see that on the lateral radiograph. Everybody has seen such a big heart, so it's a big round heart, and that dog also has pulmonary edema.
Let's come to the echocardiography.
So on echo, we can see an increased end systolic diameter
due to a decrease in myocardial contractility.
We also might see an increase in end systolic diameter, in end diastolic diameter, which is usually secondary compensatory. So we also call it volume overload. The chamber basically grows larger to maintain the stroke volume. An enlarged left atrium, or also the right atrium, can be seen if the disease is progressing. So, but basically our diagnosis is based on detecting the systolic dysfunction and also a secondary dilation of the heart. So here we see now a typical heart of a Great Dane, actually, with a big heart that has a poor contractility. There's also pleural effusion. The left atrium is enlarged, the right atrium is also enlarged, and the systolic function is very poor, as we can see already here. Here we have a so-called biplane echo, which means we have here with a 3D echo probe, we have just made a cut along this line, and this is rotated 90 degrees. So this is the short axis, and on the left side the long axis, also showing the poor systolic dysfunction. And then the same thing can be seen on the short axis with the systolic dysfunction, especially the left heart here seems not to contract properly. This can be also appreciated if we look at the M-mode measurements. There should be a much better systolic function. There is a volume overload. So here this is a quite easy to diagnose case. And then typically we also do echo from the left side, where we see the left ventricle, the left atrium, and the mitral valve in between. On the left side there is the right ventricle and the right atrium, and it shows a poor contractility and a volume overloaded heart. Due to this volume overload, we get a secondary mitral insufficiency in many cases, as we also can appreciate in this picture. This dog, in addition, also had atrial fibrillation. And atrial fibrillation, if you measure, for example, here the mitral insufficiency by continuous wave Doppler,
you can see that it has very different height in its maximum velocity.
That is due to the different filling times with atrial fibrillation. The heart is very irregular. If there is a little longer period for filling, then you have a higher backflow, whereas if the heart rate is very fast, there will be lower flow. One method that came up the recent years is the so-called Simpson method of disc. This is the recommended method in humans to assess the volume status. And it has been shown in humans that M-mode measurements for volume measurements should not be performed, and the same is what we also recommend here in animals. So with the Simpson method of disc, you basically can do that here in the right parasternal long axis or here in the 4-chamber view. And what you do is you basically start at the mitral leaflet and then you trace the myocardium, you click, and then you show where is the middle, and then these lines here are drawn by the software. And what it does is calculating little discs, and then it summates all these discs on top of it. The advantage is that if you have geometric changes, for example, more the base is bigger than the apex, then you still can calculate a quite good volume of these dogs. We had evaluated that method here in Dobermans a couple of years ago, and found that this Simpson method of disc is a very sensitive but still very specific method to enable an early diagnosis of DCM. It is actually better than M mode, and it is considered to be the new gold standard, at least here in Doberman Pinchers. If you calculate the volume divided by the body surface area for end diastole would be 95 milliliters, and for end systole it would be 55 milliliters per meter square. So what about other breeds? Can we use the Simpson method of disc also in other breeds? And here's a good update for you. Recently, more and more studies came out to provide breed-specific reference values. For example, in Salukis, in Whippets, in Great Danes, there are some reference values, in Boxer dogs, in Dobermans, and now there is also a paper accepted about Simpson method in concerning allometric scaling, where we made a big study with over 1,000 dogs to calculate breed independent reference values. It will be published in Journal of Veterinary Internal Medicine in the near future. Other parameters that are actually quite good to diagnose DCM and a systolic dysfunction is actually to measure the E-point to septal separation. So it's called EPSS. EPSS is the shortest distance from the E-point of the mitral leaflet when it is opening. So you basically measure the distance from the opening of the leaflet to the ventricle. And we do that usually from the right parasternal long axis or short axis time. It is a parameter that has a strong correlation here with ejection fraction, for example. So the bigger the EPSS, the worse is the systolic function, or the worse is the ejection fraction in humans. So this is a quite old parameter to measure, but it is actually quite fast to do, and I often like
to do the EPSS.
When I start here with the right parasternal long axis, it's quick to do. Just turn on your M mode and go through the tip of the mitral leaflet. And we have evaluated that also in Doberman Pinchers, where we found a cutoff value of 6.5, and it had a very, very high sensitivity and specificity. EPSS was actually better than M mode alone. And it was similar good as Simpson method of disc. It is a good parameter, and I was surprised actually how good that parameter performed. So I highly recommend you to use EPSS as a first screening test. If EPSS is very small, it is very unlikely that the dog has a dilated cardiomyopathy or a systolic dysfunction. What about biomarkers if we can't do echo? So here many studies have been performed on various biomarkers like troponin I or Antiprobium P. Just as an example, we did here troponin I measurements in Dobermans. We're in different stages of the disease, and so here we have the control groups, and here are the dogs that only had VPCs, and you can see it's not that great to detect VPCs because about half of the dogs with VPCs have no increase in CTNI. And the more the disease progresses, here are the dogs with only echo changes, and here echo and VPCs, and then in the clinical it is getting higher and higher and higher. Quite interesting is this group here, the last normal stage. And those were dogs that were completely normal on echo and also on 24-hour ECG. But these dogs developed DCM within 1 year. And as you can see, troponin I was already increased at that stage. So we are often using troponin I as an additional test in addition to the echo and also to the 24-hour ECG. And depending on which generation of troponin I you are measuring, there are different cutoff values, but for the traditional one, for example, 0.22 nanogram per milliliter, that was the cutoff value where we would recommend that the dog comes for the next examination not in 1 year, but maybe already in 6 months, because he might have already very early DCM. In another study that I did not include here, by Lena Klüser, also from Munich, we found that troponin I, in addition with a big heart, actually predicted sudden cardiac death if it was 0.34 nanograms per milliliter. Again, normal values do not exclude DCM, so 24-hour ECG and echo remains the gold standard for screening for the occult disease stage. Similar things was detected here in Dobermans, where we evaluated Antiprobium P in different stages. And here you have a similar group settings, and what you can appreciate here, if we put the cutoff value at about 500, again, VPCs are not so good detected. However, here, this is cool. Echo changes and echo and VPCs, actually, they will show already increased levels above 500. So, Antiprobium P is an excellent pre-screening test if echo is quite expensive or is not readily available. So if you have owners and you want to, and they do not want to have an echo performed, or it's not possible because the next cardiologist is very far away, I would recommend to measure Antiprobium P. And if that is above 500, which, by the way, this is a Doberman specific cutoff value, is much lower than in other breeds.
And this cutoff value is only used for screening
DCM, for early cardiac enlargement or systolic dysfunction. So then the last diagnostic test that would be available would be genetic tests. There are a couple of genetic tests currently offered. Most of them come from the US. For example, here is a so-called PDK4 mutation found on chromosome 14. It has been published and it's commercially available. We had evaluated that test here in dogs from Europe, and we did not find an association with it. So it might be more a specific thing in the US. Maybe it developed more with that disease, with that breeds and families that they have there. In Europe, we did not have any correlation here. When we did a genome-wide association study, we found a defect in chromosome 5 that was significantly associated with DCM, and we are currently doing another genome-wide association study as a multi-center study, and will be also quite interesting results coming up in the near future. So stay tuned for some more updates in the near future. What you also can see here, the peak was only found on chromosome 5, whereas on the 14, where the US mutation was found, there was no peak at all, which means it's probably in Europe a different one. And say this mutation does not explain all the cases that we found, and it's also not commercially available at the moment. So in conclusion concerning the genetic tests, DCM is not a simple monogenetic trait where a single mutation with full penetrance is responsible for all cases.
Approximately 50% of the DCM
affected Doberman Pinchers carry that risk allele on chromosome 5. This is for sure a major but not the only genetic risk factor for DCM in this breed. And there are some other genetic mutations published recently which needs further investigation from others and also from our sides. So if we just briefly summarize how to perform good screening examinations in various breeds would be, for example, if you look at the Irish Wolfhounds, we should start to screen these dogs with 3 years of age. We should do a clinical examination, and then because of the high prevalence of atrial fibrillation in the early stages, it is certainly good to do an ECG to detect atrial fibrillation, and if possible also an echo, but atrial fibrillation is certainly the first test that can be also done in practice. If we look at the boxers with ARVC, a Halter examination is the best screening method. Here, more than 100 VPCs in 24 hours are very suspicious, especially with the presence of couplets, triplets, and runs. On the ECG, we can find these VPCs with a left bundle branch block pattern. The limitation here is similar like in Dobermans, that these VPCs are not always present. It also has a low correlation between the 5-minute ECG and the Halter examination. Echocardiography is only abnormal in advanced stages, and there's also a genetic test offered, which might work in the US, but it's currently not recommended in Europe because there was not a good correlation with it. The diagnosis of DCM in Great Danes should do a clinical examination, yearly echocardiography from 4 years old on. An ECG should be performed, and if the owners are very into screening and money is not the biggest issue, I would also recommend to do a Halter because of the VPCs that we detected recently. That is not an official recommendation, it's just based on my clinical experience. Concerning early diagnosis of DCM in Doberman Pinchers, the optimal screening, because of this high prevalence of over 50%, which means every second Doberman is affected by the disease. Every second Doberman. Sooner or later in his life, he will get the disease. So we would recommend to do a yearly echo and Halter examination, starting with 2 to 4 years of age, and then also troponin I. However, because that costs potentially, depending where you live, a lot of money, and not always an echo is performed, is easily available to be performed. Here would be an alternative approach how to diagnose the disease. You could make a combination of clinical examination, ECG, and then the biomarkers, Antiprobium P or troponin I. I still don't know which one would be better, or if the combination of both would be superior, I would guess, but we have to do more analysis on that. Antiprobium P is really good to detect early echo changes. Troponin I is in general a good marker of a myocardial disease. So if you find at least one VPC in the ECG, or if the antiprobium P is more than 500 or the troponin I is above the cutoff value, it is strongly recommended to do an echo and a Halter examination. So that might give you more arguments for the owner that an echo should be performed. Concerning the therapy of DCM, well, we need to treat the arrhythmias. For example, if there is atrial fibrillation, I often like to start with digoxin, and if the heart rate is quite high, then probably digoxin alone is not sufficient, and then you can combine digoxin plus diltiazem, for example. That's an excellent combination, or the combination of digoxin plus sotalol. I also would like to mention that you have to look at the atrial fibrillation maybe on a 24-hour ECG, because many dogs with atrial fibrillation actually also have ventricular premajor contractions. And then digoxin is not good for VPCs, and diltiazem, a calcium channel blocker, is also not working for VPCs. So then it might be actually better to start the dog on a drug that can treat both
atrial fibrillation
plus VPCs, and one of these drugs, for example, would be sotalol. Sotalol is a potassium channel blocker which also has calcium channel blocker properties. So class 3 plus class 2. It is a very good drug in boxer dogs. It is also very good in Dobermans, and you can combine then, for example, sotalol with mexiletine if it's still available in your country. In Europe, mexiletine is currently not available. Other beta blockers would be also okay for ventricular arrhythmias. Some beta blockers like carvedilol, for example, that are highly used in humans. My clinical experience was not that great with carvedilol for the suppression of ventricular arrhythmias. Amiodarone is a very good drug for VPCs. However, I would highly recommend that this drug is only used if you already tried other drugs and they did not work, as a last thing to use, because it has numerous toxic side effects. On the other side, if you control those, they might be reversible, like the liver toxicity, and it's a very good drug. So we use it quite often in Dobermans with malignant type of arrhythmias. Then other drugs for the treatment of occult cardiomyopathy would be, for example, an ACE inhibitor. ACE inhibitors in humans are recommended if there is a reduced ejection fraction. And there are nice studies that showed an advantage. In animals, we actually only have here one retrospective study, also performed in Dobermans, because Dobermans have such a high prevalence, so it's quite good model to try some drugs. And in that retrospective study, it was a 44% reduction to develop congestive heart failure.
And it seems that whereas in mitral valve disease, ACE inhibitors are not that useful,
that potentially in dilated cardiomyopathy, that's a different story. So here also more studies are ongoing, and also we need further studies to clarify if an ACE inhibitor in the occult stage of cardiomyopathy is actually beneficial. A drug that we use for heart failure in dilated cardiomyopathy all the time is Pimobandan. And the PROTECT study here showed that Pimobandan in the early stages of the disease is beneficial. So in that study, Doberman Pinchers in the occult stage of the disease, so in stage B2, were included. So they had a systolic dysfunction plus minus ventricular arrhythmias. And they were randomized to placebo or to Pimobandan. And then it was looked how long does it take until these dogs develop congestive heart failure. So if we look at the primary endpoint, Pimobandan, that's the red line here, the median time was 718 days versus 440 on the placebo group. So that was highly significant, as you can see here. And since that PROTECT study, it is recommended to use Pimobandan from the moment on when you detect a systolic dysfunction plus or minus a dilation of the left ventricle. The prolongation of the preclinical stage of DCM was on average 9 months to the onset of congestive heart failure or to sudden cardiac death. So Pimobandan should be started once echocardiographic changes are detected. Also in heart failure, there is a small study, however only a small study, that showed also again in Doberman Pinchers that Pimobandan should be given to dogs in heart failure. And I think nobody would doubt that Pimobandan is very beneficial in dilated cardiomyopathy cases. If the dog then develops, unfortunately, congestive heart failure, so pulmonary edema, pleural effusion, ascites, for example, we need diuretics. Traditionally, we used furosemide, but now torocemide is another approved diuretic, approved here in Europe for the use in animals. But other diuretics can be also used for sequential nephron blockade. Sequential nephron blockade is something that, for example, I start with torocemide, and then I increase the dose when the disease is progressing. But then instead of going higher on only one single drug, maybe I combine it with a second diuretic to block different areas on the nephron, different transporters. For example, hydrochlorothiazide is a drug that I like to combine with furosemide or torocemide, and the same accounts with spironolactone. Spironolactone is not a very strong diuretic, but it is, in addition for the sequential nephron blockade, potentially beneficial. Also potentially the combination of ACE inhibitor plus spironolactone
for the use in
congestive heart failure. So Pimobandan for the systolic dysfunction, diuretic for the fluid diuretics, and then ACE inhibitors, spironolactone as antifibrotic drugs, is against the renin-angiotensin activation, and then additionally we should use some antiarrhythmics if needed, for example digoxin for atrial fibrillation. Before I come here to torocemide versus furosemide, maybe one thing about beta blockers, sotalol, and so on, these drugs that we use for ventricular premature contractions. Be careful that you do not start them in the in the full dose, because potentially if you give a full dose of the drug, then you can decrease the contractility. And if you have a dog already with DCM, you don't want to do that too fast. So we like to titrate
the antiarrhythmic drugs slowly up.
Maybe a quarter of the dose in the first week, half of the dose in the second week, and so on. And then we go stepwise higher so that we are not overwhelming the beta receptors, for example. Coming here to torocemide. Torocemide is a drug that has been recently approved also for veterinary use. There are several drugs available.
Torocemide once daily is equal to furosemide
Twice daily, that has been shown here in the test study. And it was in that study also associated with a twofold reduction in the risk of reaching the secondary composite cardiac endpoint. That was in dogs with degenerative disease. On the other side, we can probably without any doubts use that also in dilated cardiomyopathy. We are using it quite often. So how do you pick the correct dose? Well, usually the conversion factor was thought to be 1/10. Recently we thought more it's about 1/20. But this is only that you get a feeling if you're used to give a certain dose of furosemide. So for example, if you would give would give 2 milligrams per kilogram twice daily of furosemide, that would equal to 0.2 milligram toracimide once daily. So that conversion factor works quite nicely. For me, the long half-life is actually quite nice. If we have advanced cases, then we often need to give furosemide 3 times daily in the end-stage phases. And 3 times daily to give a drug is quite difficult. So here, toracimide, for example, I can give it usually in the beginning once daily, and then later I go up to twice daily. But I never need to go to 3 times daily. So that's quite nice. And we need to give less pills, which is also, especially in large dogs, more useful. If there are additional benefits like antifibrotic properties as they suggest in human medicine, we don't know yet, but it's an interesting drug, and I have to say it replaced in our clinic furosemide for a big part already. So now we come to some future directions. And I briefly wanted to show you some results of some recent research that we are working on. And that was here published in PLOS ONE about autoantibodies. So in humans, it is well known that autoimmunity associated with autoantibodies against, for example, beta-1 adrenergic receptors is increasingly accepted as driving human idiopathic dilated cardiomyopathy. It's also called functional autoantibody disease. So it can trigger, promote the disease. And so the first part, what we did is we wanted to see if, for example, Doberman Pinchers with DCM also have autoantibodies, and the results of that study actually was yes, they also have these autoantibodies. So what do we do with these autoantibodies? In humans, they tried to use immunoabsorption. And then they showed that this actually is quite beneficial for the humans that got the immunoabsorption. Problem is that this is quite time-consuming and expensive and not lasting for very long. So that brings us to some new molecules, and they are called optomers. Optomers are a new class of molecules, and they are short single-stranded
DNA or RNA
oligonucleotides, and they bind with high affinity and specificity to their target. So they can bind and neutralize specifically diverse autoantibodies. The advantage here is that they are chemically quite easy to produce and adaptable, and they would be easy to apply, and they have very few side effects. So we just recently published a study where we used these optomers in Dobermans with DCM, and that was published here in European Society of Cardiology Heart Failure, so a human paper. That was a prospective clinical control study where we had 3 studies groups with 14 Doberman Pinchers each. So in the optomer groups, we had dogs with DCM and the beta-1, and they were treated with the optomers. Then we had a control groups where we had Doberman Pinchers in similar stages of DCM with also autoantibodies, but they did not receive the optomer treatment. And then, because we saw really good results, we were wondering if that has to do with the group selection or whatever. So we formed a second control group, a retrospective control group without the optomer treatment, which was exactly matched to the treatment group. So we wanted to make it as difficult as possible for the optomer group by comparing it to two control groups. So I just show you here the results of the control group 1, and you can see already here it's quite impressive. In the control group 1, it was 266 days
to reach the study endpoint, whereas the group that received the
optomers, they had a significantly longer survival time of about 306 days, so almost 1 year longer if the dog received the optomers. And what the cool thing is about these optomers is they only got a one-time infusion over 20 minutes of that drug. One-time infusion, and then you have 306 days longer. I think that is very promising. That is something that needs further investigation in larger dogs, in larger groups. But that brings us also to the summary, and then also I'm very happy to answer your questions in the live session about further treatments. There are a lot of studies ongoing concerning what is the best antiarrhythmic drug. How can we better define which dogs need Pimobandan in the early stages? The SHIELD study is dealing with that retrospectively and will be published hopefully also in this year. Genetic markers are more and more detected, combination of biomarkers. So it's an exciting field, still a lot of work to do. New echo parameters, for example. And in this short lecture here, I hope that I was able to show you a little bit how to early diagnose DCM in different breeds and also how to treat it. And now we will come to the live session.